very much for having me to your meeting tonight. I'm coming to you from far north New South Wales. I live on Bundjalung Nation, so I'd also like to acknowledge the traditional custodians of our land. I'm just going to start my slideshow. Lauren, just let me know if you're not seeing that. I'm hoping that you are. As Lauren mentioned, I'll be talking about exercise interventions in residential aged care, particularly in light of the new MBS item numbers that are available and temporarily from now until June 30 next year. And I'm hoping to have a bit of a clinician's lens, although it is based on the evidence that I'll share with you, a clinician's lens so that you can take away information about what works in residential aged care in terms of exercise and what does not, so that we can make the best use of the new MBS item numbers. So let me just click on here. The learning outcomes, the plan by the end of my session, I have 40 minutes with you. I'll allow time for questions at the end, but I am happy if you'd like to interject along the way using the chat function. And perhaps, Lauren, if I'm chatting away and you see something there that would be worthwhile speaking about at that time, just feel free to interrupt me. So we're going to look at the benefits of evidence-based exercise in residential care. We'll discuss the challenges for allied health professionals working in residential aged care and some of the new enablers that are available to us right now, and map best practice exercise service with those new MBS items as I mentioned. So I'll start with a brief background, my insights as an experience as a clinician, and then why there was a need for evidence to try and advocate for change in this setting. Some of the outcomes of a cluster randomised controlled trial I conducted in 16 aged care facilities, and the translation of the findings from this trial to practice and policy. Then it'd be good to focus on some practical tips, look at a case study, some take-home messages for clinicians, and the barriers and enablers to best practice allied health in that setting. As I mentioned, I'll allow some time at the end for question and answer. So let's just have a little snapshot of how we got here. Basically, I started working after about 20 years as a private practitioner and predominantly in the sports setting. I came into residential aged care after making a green change up here to northern New South Wales. But I was really disillusioned early on with the way that allied health services were funded in residential aged care. At that time, the aged care funding instrument was quite new and there was a little window open for stakeholder feedback. So I had a look to see if there was evidence to show the government that they were funding, in my opinion, the wrong thing, and found that there was hardly anything there. It really was an underrepresented cohort, residential aged care. So then I had to make a decision either to get out of this field and go somewhere else. But I really loved working with older Australians, and I could see that with a little bit of sort of common sense physio, you could really make a difference to people's lives. So I embarked instead on a journey to try and advocate for change. So the funding for allied health, for those of you who work in it, you'll be very familiar with aged care funding instrument ACFI. And for those of you who don't, this was developed in 2008. It is the means by which residents are funded in residential aged care. It is very prescriptive. It is currently about to going into its swan song. It's going to be replaced next year. But the sort of things that we have been allowed to do under ACFI are manual handling directives and education. In the beginning, when I started this, it was physio only. There wasn't room for any other allied health professionals with the funding. That expanded to include OTs and exercise physiologists. But we're still all funded to do the same things despite our differing expertise. And these things are manual handling directives regarding mobility and transfers. Sometimes we're funded to do a pain assessment, sometimes we're not, but we're certainly funded to deliver interventions for pain management. And the interventions we're funded to deliver are massage or TENS or other electrophysical agents. And there's no accident that I have black and white photos, because pretty much these particular modalities were well and truly outdated many decades ago in terms of best practice. But they're still the mechanism, the only things that the funding mechanism will approve at the moment. CHC4A means complex healthcare 4A, which is delivered, TENS or massage or similar, delivered 20 minutes a week by a registered nurse or an allied health professional, or a complex healthcare 4B4, lots of 20 minutes a week of the same treatments. So understanding that, what we're seeing there is no funding for the evidence-based or evidence-informed practice that we see in other settings, such as tailored assessments, planning and goal setting, and therapies to support these things, such as exercise. In fact, there's no funding at the moment for any preventative healthcare, reablement or wellness under ACFI. In fact, there's a perverse incentive, and that is that aged care facilities are given more money, more financial reward, the more disabled their residents are. So apart from the fact that that's somewhat abhorrent, and that's been recognised by the government, who have been partnering with Kathy Eager and crew from Wollongong, and they've come up with a new funding instrument, which will be implemented next year. And that one does remove the perverse incentive, I'm pleased to say. But in terms of the background and how we got to where we are, there was a real mismatch between what I was seeing by implementing some exercise treatments back in sort of around 2010-11, and really changing lives with what was being funded. And so it was the luck of the draw. If you worked in a residential aged care facility that had wellness at the core of their belief system, then you were funded to deliver these sorts of reablement programs. But if you didn't, then it was just the TENS and massage that people were getting. So it was both a waste of clinical expertise and a real shame for the residents. In fact, I do recall a beautiful resident told me once in a very fancy aged care facility that looked amazing, but she said to me, "We have 4 levels of care here, dear. We have high care, low care, no care, and who cares?" Anyway, that really stuck with me. I thought, we've got to change this. Now, I started to look at what might make the government listen, and obviously the humanitarian improvements are important, but so is cost effectiveness or an ability perhaps to save some money. So when I was trying to decide, okay, there's not enough evidence here, we're going to have to conduct some sort of a trial, what will the government be most likely to listen to? Falls was a key outcome, and it turned out to be the primary outcome of this study, although I must say it's really quality of life, mental health, those sorts of things, seeing a person's life change that were my personal drivers. However, we chose falls as the primary outcome for the trial because they're so prevalent in residents of aged care, almost double what you see in the community. The leading cause of preventable death. We know that we're going to have a lot more people living in resi care by 2050. Probably I'll be one of them. And we know that no other injury, including road trauma, costs the health system more. So to take a look at falls, as a physio, I was looking predominantly at those 2 blue things, but we do need to acknowledge that falls are multifactorial. It's not just strength and balance. And if you have somebody in front of you who has it's a polypharmacy, for example, reduced cognition, pain in their foot, Parkinson's disease, cataracts, and requires a pacemaker, then just doing strength and balance alone is not going to be enough. There's a real role for multidisciplinary care in falls. But for the purpose of this particular presentation, I'm going to concentrate on the exercise approach to the management of falls in the setting. So I looked back then to see what is best practice recommendations regarding exercise for falls prevention in residential care, and found that there was not many studies, and the results of those studies were inconsistent. And there was also reports that because of that, institutions worldwide were saving costs and removing exercise programs. So I took a look then at the exercise literature. What were the Cochrane Review looking at? There, as you can see, it's just a little handful of exercise related trials in those days. And some of them worked. They're on the left side of the line. Some of them didn't. They're on the right side of the line. But if you look at the mathematical amalgamation of that, you come out with this black diamond down the bottom that says we don't really know whether it works or not. And then I had a light bulb moment. Exercise, those of us who work in exercise regularly, we know that exercise is like medicine. And so that means the type of exercise, the dose of exercise, and the frequency of the exercise all matter. It'd be similar to saying, for example, taking a diabetic person with type 1 diabetes, insulin dependent, and giving them Panadol rather than insulin. It's the wrong type. Even if you gave them the right dose and frequency, they're not going to get a change to their blood sugar levels. But then throwing out medication as a holus bolus and saying medication doesn't work for diabetes, that would be wrong because it wasn't the right type of medication. In the same way, we're starting to find out now, as our understanding of exercise science improves over time, that the type of exercise you give, the dose and the frequency all matter as well. So what if all those studies we were looking at were doing the wrong type and dose of exercise? So the next step is to have a look and say, what is the right type of exercise to try and reduce falls in the oldest old? And thankfully, very lucky for me, about the same time as I was looking into all this, there was Anne Tiedemann and Kathy Sherrington published a paper about exactly that, the key components of best practice exercise in the oldest old to minimise falls. It was quite a heavy dose, 50 hours minimum, high level balance, strength if you're deconditioned. Everything needed to be individually upgraded and progressed, closely supervised to allow for safe inclusion, and there needed to be a maintenance program after people had initially strengthened up. And interestingly, a walking program, while it was beneficial for other things, should not be considered a falls prevention program. I had to think about that, because at that stage I was a bit guilty of thinking, well, surely any exercise is better than nothing. If people are sitting around a lot in their chairs, which residents are, maybe just doing anything is better than nothing. However, it seems that if you ask people to just start walking without first improving their balance, their strength, their righting reactions, in other words, their ability to catch themselves at their fall, might lead to disaster. And that's what they found. When we looked at these exercise programs that I just showed you a moment ago that had been examined, the one on the far right here, I'm not sure if you can see my mouse, but the one on the furthest right, that was a walking program. You can see it actually increased people's risk and rate of falls. So none of those exercise programs had actually implemented the key components of best practice exercise. And that's really what I want you to take home from today. One sort of exercise is not the same as the next sort of exercise. You have to be really strategic if you want to improve physical performance and reduce falls in residents of aged care. A blanket sitting people exercise program where you sit everybody down in front of a DVD, which is something you'll see in a lot of aged care villages, is just not going to cut it. So I enrolled as a clinician with a bee in my bonnet, and despite my passion, I knew that I was going to need support from academic heavyweights to make sure that if we're going to go to all the trouble of implementing a randomised controlled trial, that it was done with appropriate academic rigour. So Professor Catherine Rashog is a physio, Stephen Goodall is a health economist, Lindy Clemson's an occupational therapist, and Tim Henwood is an exercise physiologist. And together with this amazing multidisciplinary team, we conducted a cluster randomised controlled trial in 16 residential aged care facilities where those little sunbeams are. I live up near the Queensland border, so you can see quite a few of them were up my way. We had 221 participants in the trial. 113 were randomised to receive the intervention and 108 to receive usual care. So we had to recruit the aged care facilities in pairs, and then our exercise program was performed in one aged care facility and the other aged care facility act as a match control. So otherwise we'd end up, for example, with 20 residents volunteering to participate, and we'd have half of them attending the gym and the other half not within the residential care facility. We decided it was going to be really difficult to keep that clean and make sure that people weren't sneaking in there and doing some exercise when they were randomised to the exercise to the control group. These are the baseline measures. You can see there was a bit of a difference in the falls and the fallers between the intervention and usual care groups, but that was not found to be statistically significant. But it did worry me for a few years before I knew the results, because those people in the intervention group were actually more likely to fall, given that there was more of them and they fell more often in the year prior to the randomisation. I'll just run this video now to show you what the intervention looked like. We actually did use resistance training equipment here because there was a lot at stake, and that is that up till now, exercise was getting a bad rap. So we wanted to make sure that people were genuinely exercising at a dosage that was likely to cause a change to their strength. They also needed to be able to exercise at a high challenge balance. You can see that's a smart card system. So each person had their own exercise program individually prescribed by a physiotherapist at the time, so that they could do 2 sets of 10 repetitions at a moderate to somewhat hard intensity for each of the exercises. I'm going to go through them more closely shortly. And then we did these high challenge balance exercises. So that's not actually a shoulder exercise, that's a balance exercise, because all those people are not holding on. Now for this, going up on their tippy toes and down, they could use the table if they needed. One of those people's 100 years old. And might I say, never came to the exercise program once until the camera rocked up. So this is static balance. It doesn't make for very entertaining video, but people either had their feet together or in a semi-tandem or a tandem position. This is reaching outside the basic support, rocking like they're on a boat. So they rock from side to side and reach. Now remember that this is not actually a shoulder exercise, so if you can't get your arm out, it doesn't matter. It's more about the rocking than the reaching. And then this last one is reactive stepping or recovery steps. So that's falling, falling, catch, falling, falling, catch. And so people would basically catch themselves from falling. You look at the lady in the yellow and see that this is actually not for the faint-hearted. So you have a table in front and a chair behind, and put your volunteer or your allied health assistant close as possible to the person with the highest fall risk. Now this one, sorry, the poor quality is on my iPhone, but I wanted to show you this is a cognitively impaired group. It was a high proportion of helpers and compared to the group size. I'm teaching him here to do the grapevine that you saw on the previous slide, and same with this fellow. Step out, behind, behind, behind. Step out, in front, step out, behind. So it is high challenge balance. The beauty of having the gym equipment there, this is tandem walking, is that I could have at that time 5 people exercising at their own individually prescribed resistance training setting on those machines, and they're all seated, which meant that I was then freed up to do the high challenge balance work, so it worked well in a group. This chap, I'll just see if I can get him to start. This chap had Parkinson's disease, and we used to have to time it so that he'd had his Matapar before the exercise session. And this type of step, step, up, up, down, up, down, with the cueing, you can see he was so thrilled with himself, he actually started to sprint it. So what were the outcomes? After 12 months, there was a surprisingly, thrillingly different finding for those in the intervention group compared to the usual care group. You can see the falls rate, which is falls per person year. That's a 55% reduction. Total number of falls was different. Number of fallers, the number that fell, recurrent fallers, injurious falls was statistically significant as well. Ambulance attendances and so on. It wasn't powered to detect changes in fall-related fractures, and there really wasn't much to say between the two groups there. But for all the other outcomes, in particular, this one, the incident rate ratio was 0.45, and the confidence intervals are very healthy, which tells us around a 55% reduction in falls. There's also a statistically significant improvement in balance, gait and chair stand, so physical performance.
Hi, Jenny.
Yes.
Sorry, we just have a quick question asking
Sure.
about any stats on dementia patients.
Yes, I didn't have any until about a week ago. We've done a subgroup analysis, which we're preparing now for submission to a peer-reviewed journal, but the subgroup analysis on people diagnosed with a cognitive impairment found that the falls rate was reduced by 50%. So 55% in the overall group and 50% in those with a cognitive impairment. So that's exciting, and we're just waiting now to prepare that to be submitted for publication as well. So let's get to the meaty bit of what to do if you're the clinician, now that we know the background. So the total dose, we aim for 50 hours, which is 2 hours a week, but we actually found that you had that protective effect even with 30 hours spread across that 6-month period. So about 72 minutes, give or take a second, per week did produce an effect as well. We included the big muscle groups, knee flexors and extensors, hip extensors, abductors and adductors, triceps to help push out of the chair, calves. The high challenge balance exercises included standing bicep curls and shoulder retraction. So that was more of a balance exercise, and people either had their feet sort of shoulder width apart or together, or a semi-tandem or tandem. The heel raises you saw in the video, the dynamic balance, those recovery steps, that's that whole falling, catch thing, and the grapevine. Static balance included feet side by side, stride, semi-tandem and tandem. And we could make it more complex by asking people to open and close or close their eyes and reaching outside the base of support as you saw. Now, balance is a bit boring. So since this Sunbeam program finished, I supervise students up here on their rural placements. And a lot of our student programs have been about trying to keep people interested in balance exercises. So the sort of things that we've done is a bit more person-centered, which also adds to the enjoyment, of course. The fellow on the top left loved boxing in his past, and so we made boxing part of his balance program. The little lady here on the right had a wow of a time with the Nerf gun, which unfortunately included shooting me, but never mind. We had a target set up in front of her, a chair behind, chair in front, and we get them in the same position, so feet hip width apart or together, semi-tandem and tandem, that kind of thing, to just make it more interesting while you're standing there in a static balance position. The students have also included dancing exercises, as you can see on those bottom two left slides, and myself on the right there. And then the one you see with the black frame around it, that was a couple of male physio students who realised that men are seriously outnumbered in most residential aged care facilities. And so they developed the MAN plan, which included a whole lot of balance type exercises woven into things that the men's club might like to do. So you're seeing beer pong in action there at the parallel bars. And we bought a football table. You can see the fellow's got himself up out of his wheelchair to help assemble it. And then they used to stand to play it as well. So there's a growing evidence base now challenging the myths about exercise with older adults and the dosage in particular. It's not just from the Sunbeam protocol, but the ACSM guidelines are now looking at 2 to 3 times a week, 2 to 3 sets of 8 to 12 reps, large muscles, multi-joints. So that's similar to what we did. The National Strength and Conditioning Association have got similar recommendations. So the lobby for change, and this is where we're getting to now. This is Professor Stephen Lord, who is a world-renowned researcher and expert on falls prevention. What works in residential aged care, we now have one gold bar, which means one study with good methodology that's shown a positive effect. So whereas I mentioned earlier there was no evidence for exercise in this setting, now there is that one trial and there's some others coming along. Persistence is key if you want to make a change for residents. So this is me last year at the Royal Commission into Aged Care. And I'm thrilled to say that as in response to the interim report put out by the commissioners, Minister Hunt in December made an announcement, or November, he made an announcement that there was going to be money allocated to helping get people back on their feet after COVID, particularly in aged care facilities directly affected by COVID. And so that included the extended Medicare items. So there is light at the end of the tunnel for those of you thinking, well, this is all well and good, but we still can't do it. We're still not funded. And that's what I want to spend the last bit talking about. So in terms of your PHN, there are temporary MBS items for allied health and residential aged care. And there are temporary funded, the Sunbeam program is also being funded in 11 PHNs, but that's not including yours at this point. I've put a link here, which I hope you'll be able to access later if you're unaware of this. And I found out recently that a lot of clinicians aren't aware that there are new MBS items. They need to, for allied health, so this is for physio, EP and OT, you need to access them in order to be able to deliver them. You need to have a referral similar to CDM type referral through the GP. There's new items which included a higher flag fall fee to get out there and do an initial assessment. I'm not going to go through this in great detail. You'll need your practice managers to look into this and look up Medicare directly, because I just really want to get into the how to translate it into practice. So there's 5 additional services in addition to the ones that we're always able to claim in residential care. Now, you might not have seen this. There is a video that will give you a lot more detail than I can give you in this time frame that tells you how to implement the Sunbeam protocol with or without a gym, and that is the link for it. This will be made available after tonight's session. And this, don't be horrified by this, but this is actually a prescription sheet that I wrote for the group therapy programs. On the page on the left, it shows how to perform the exercises if you don't have a gym, and the page on the right is a record keeping sheet that will both remind you what to do and how to progress it, and keep a record to minimise that paperwork. That page has tips on how to prescribe each exercise, and I've also made the Borg scale resource that you can see here, because we really want people exercising in that somewhat hard, moderate to somewhat hard range. If it's too easy, they're not going to get any benefit. If it's too hard, they won't come back. So each exercise needs to be performed 2 to 3 times, 10 to 15 reps. I go more for the 10 now that we know more, at a moderate to somewhat hard resistance. So you can see here the knee extension. If you don't have a gym, you might do it like that one on the top left. Knee flexion, you might do like this. You've got to be careful of skin integrity, etc. The next one underneath is hip abduction. So people tie their knees together basically with the TheraBands. On the right-hand side is hip adduction. That video that I mentioned earlier will go through that in a lot more detail if you're interested. I also produced an initial assessment example that you might be able to use for that initial assessment. That is a new MBS item. And this is specifically to allow you to target the right type of exercise for the person in front of you. You need to know their comorbid conditions, their areas of pain, whether they've got something particular that you might need to be careful of, like a total hip replacement. If they have diabetes, for example, you might need to have a plan in place for if they have a hypo or angina, etc. I usually just do a functional range of motion joint screen. It doesn't really matter whether someone's got 90 degrees shoulder flexion on one side and 93 on the other side. What matters is their functional range and what they'll be able to do in the exercise program. As I mentioned earlier, it's good to know if they're on particular medications so that you might time your treatment or your exercise session around that. And their preferences, of course, are important. In terms of outcome measures, it's good to use the short physical performance battery. Time will stop me going through that in great detail, but basically it's chair stand, gait speed and balance scores so that you can report back on whether things are changing. You can see below there is a recommendation on how to prescribe the initial dose. So we're going to have a look at that in the form of a case study. And that's the Borg scale I mentioned earlier. I show that to each person when I'm prescribing and ask them to point to whereabouts they feel that exercise was by the time they get to 10 repetitions. And we're aiming for something in the green. So let's look at case study with Mrs. F. This is a real person that we just saw recently. She's 90 years old. She lives in a high care facility, Parkinson's, dementia, frequent faller with fractures, OA, hypercholesterolemia, type 2 diabetes mellitus. She has an old left side affected CVA and a bilateral total knee replacements. She's also had a right spiral fracture to her humeral shaft, anxiety and depression. She walks with 1 to assist pushing her in a wheelchair or 2 to assist with a 4-wheelie walker. She needs 1 to assist getting out of a chair and 2 to assist getting in and out of bed. She's an amazing woman that has some family in Queensland, which is not very helpful with our border. She was a hairdresser, a swimming instructor, so she loves to exercise, and she's written an amazing book, which I couldn't put down. So I just wonder if I might be able to open up, if anyone would like to point out some barriers they think she might have to exercise. If the cat's got everybody's tongue, do you think Laura and I will move through so we have enough time for questions?
Someone has said mobility access.
Yeah. So if you're 2 to assist with a 4-wheelie walker, you know that it's not going to happen very often for you because the staff are busy and the ratios are lousy. So this is where, you know, the potential that would fall under others here. But her cognitive impairment, her balance problem, her falls risk, the locations of the fracture, OA, so she's got pain, Parkinson's disease, left-sided weakness, availability of equipment, availability of supervision, as you'd mentioned there, are all potential barriers. But what we did, and this is just giving you a little glimpse of how to use that tool I showed a moment ago, the students and I spoke to her about her personal goal. She just wanted to be able to get back to walking around with a four-wheelie walker inside the village rather than waiting for two to assist or someone to come and push her in the chair. So we sat down and went through that list of exercises that you can see in front of you. And what I really want you to see from this is that the knee extensors were to be done using red TheraBand, 2 lots of 10. That's where she started to get tired, whereas her right, that's the left side affected with the CVA, whereas her right side, she could do a stronger band. Similar for the knee flexors. The leg press was also different colours. The hip abduction was done, as you saw, with the knees tied together, pushing out against green. She had the star ball to squeeze on for the hip adductors. So you can see that the exercise program is quite tailored. It's using different bands, that's her starting, and we'll move up till she can do 2 sets of 10, then 3 sets of 10. And then when that becomes a bit easy, we start increasing the strength of the resistance band. In terms of her exercises, she'd have 1 or 2 hands-on, 2 sets of 10 for all those things to start with, building up to 3 sets of 10 and reducing the base of support or the handholds. This is a good news story. That's actually her there on the right-hand side, and the fellow on the left as well. After 5 weeks training with the students, both of these people who were wheelchair bound were back up and walking again. And it's just a crying shame if this is not happening when people have the potential to do so. So why do I keep persisting with this? I'm still working with the Department of Health to try and expand this out beyond just those 11 PHNs affected by COVID. But this fellow on the last day, I'll tell you what he said to me because the sound's a bit lousy. But on my last day of my data collection of the trial, he said to me, "A man's not old when his hair turns grey. A man's not old when his teeth decay. But a man's fast approaching his long last sleep when his mind makes an appointment that his body can't keep." And I think if we can help his body keep those appointments, then that's what we're here for, really. So thank you for listening. And I think I've got around 5 minutes left if anybody would like to ask questions, or perhaps now I can have a little peek in the chat. Yes, thank you, Lisa. If she has Parkinson's disease, I wonder what her voice volume might be like, which may impact on her communicating her concerns with you. That is a fact. It wasn't a factor with this lady, but it has been a factor with some other people. This is the beauty of having a little bit more time that you do have with students. And if you, and this is something you'll have to factor in if you're going to use the new MBS items and go into that initial assessment, you can spend a bit more time with them. And you'll have to spend time one-on-one. And you can, the Sunbeam program was a group therapy program, so you have to look out for people who can't speak up and pay particular attention. But the MBS items that we're talking about tonight with you guys are one-on-one, so that might help with that. Confidence was a huge factor. Oh, hello, old student mate. I'm not sure whether we got any other questions in our chat.
Hi, Jenny. Yeah, we've got just a couple of questions. Just in regards to the case study you did, there were some other suggestions, such as anxiety regarding joining the group.
Yes. So I didn't, what I showed you just then was not her group therapy. That was her one-on-one, because that's what you guys are going to be able to do with the new MBS funding. But she also does join the group. Repetition does help her. She does join the group, and so long, it's really up to us as Allied Health to make sure that people feel included, to make it a safe environment, to include, the things we do for that are include music that people enjoy, sit them next to people that they are friendly with in the village already, make sure that they're comfortable with before you start. But if you're doing one-on-one, which is what you guys will be able to do under the MBS, then it is actually a bit easier with all of that. Do you feel there was any carryover with social engagement and quality of life, communication and cognition? Thanks, Nikki. I think in the Sunbeam program, the group therapy program, the social engagement was a huge factor. I think with the one-on-ones, it actually is, I haven't measured this, but we are often told, the students and I are often told that we make people's day. And I think it's that one-on-one time and where they get to say what they'd like to practice today. You work with them on it and they see themselves succeed. So that's important. Repetition is really important, Barbara, as you say. I'm not sure if we've got GPs present, but if so, I really hope that you can see that one exercise is not the same as the next. Shoe choice when participating in the program. Thanks, Nikki. People wore shoes that they were comfortable in. You might have noticed in one of the videos, somebody had wetsuit booties on. If they wore shoes that were not safe, sometimes people would come down in their court shoes. One lady used to come in her court shoes, a skirt and a string of pearls. That made the balance a little bit challenging. But then we're meant to be doing balance challenge. So I'd speak to her about safe footwear. We'd certainly make sure if people's shoes were damaged, you know, if the sole's flipping about, that kind of thing, that we would go back to their room and find something a bit safer, communicate with their family about helping them to access safer shoes, that kind of thing. Anything else? No, the Sunbeam program was implemented, the trial was implemented by physios, and that's because it had no funding. And the physios at that time, the only allied health were physiotherapists. By the end of it, by the end of the implementation period, EPs and OTs had been included in the ACFI funding. They weren't included in that trial, but they certainly are included now in the rollout in those 11 PHNs. And if you're going to be using the extended MBS items, physios, EPs and OTs are all eligible for referrals. There's different item numbers, MBS item numbers, but if you access that resource, that website, the link that that will be made, that will be shared with you, you'll be able to read through and see which item numbers are relevant for which profession. Whew, by the skin of my teeth, it's 7:40. Are there any more questions?
Hi, Jenny. It doesn't look like there's any more questions, but I just wanted to thank you again for joining us tonight and presenting for us.
My pleasure. Good luck, everybody. I hope you enjoy.
Thank you, Jenny. So I'd just like to now introduce our second speaker, Associate Professor Lynette Mackenzie from the Occupational Therapy discipline at the University of Sydney, presenting on occupational therapy in aged care.
Hello, everybody. Now, are you all able to see that? Can you all see that slide?
Yes, we can.
Oh, good. Excellent. I'm always a little bit worried. All this online stuff I've been doing with students can often go wrong. So I just wanted to make sure. So thank you, Jenny, for such a lovely presentation and all those great stories of how we can positively impact on the functioning and quality of life of older people. For my presentation, I've decided to broaden it a little bit. So I'm going to talk about older people living in the community, as well as older people in residential care, and how occupational therapists generally intervene with them. I often find that a lot of people, whilst the MBS items are available, don't always know what the role of an occupational therapist can be. So I've started off with just a reminder for people of what that role is. Now, let me see, here we go. So really, for the areas of concern that an occupational therapist has in any area of practice is about the person themselves. So things about their own personal history, what their presenting problems are, what they consider important, and things about their personal identity that they want to preserve. Maybe there might be some cultural issues, and obviously age becomes an issue as you age as an older person as well. So we're interested in assessing those sorts of aspects, but we're also very interested in looking at the environment that a person finds themselves in. So often that is the home, and I consider aged care residents to be living in their home as well. So that is as much their home as if they were living in a private home in the community. We tend to be very interested in safety and capacity to continue living in those circumstances and improving them. So we're looking out for hazards, and that may not necessarily only be indoors. We're also interested in people's access outdoors and their access in the community. Of course, that's all been rapidly truncated at the moment, but older people still need to be able to gain access to their own garden, perhaps, or to be able to get to the local shops. And when we're thinking about environment, we're also thinking about social environments and how much support an older person may have to enable them to engage in the activities that they need to or want to, as well as simple things like how to navigate the health services. We find that a lot, that all the different services that are available for older people are very fragmented, and you do really need somebody to help you navigate those. And often it's the occupational therapist or the social worker that helps to make those sorts of things happen for people. And then, of course, we're interested in people's occupations. So that usually is involved in looking at people's self-care, how well they can look after themselves, how well they can manage their home. A lot of older people have carer roles as well as looking after themselves, and the kinds of activities that people want to engage in. So there's going to be a whole range of things that an occupational therapist would be asking about when they see an older person. And for us, we're interested in helping somebody gain the best level of occupational performance in their situation. So that's where the person, the occupation and the environment come together. And everybody's occupational performance is going to be influenced by one or all of those aspects of being able to do what you want to do. So I just wanted to remind you of that. It can be quite hard for people that aren't occupational therapists to think about when to refer to an occupational therapist. So that's why I tend to start off with the broad picture of OT, so that people can think about some of their clients that may well be presenting to them with partial issues around any of these circles. So we'll start off talking about older people living in the community. And as I said before, we're interested in people's level of safety, how independently functioning they can be, if that's what they want to be able to do. Obviously, some older people are more in a codependent sort of relationship about how they get on and do things at home. There's also the maintenance of valued roles. As I said earlier, some older people are carers themselves, and that might be a very valued role for someone. There's also community access and general support needs for an older person to be able to function well living in the community. I'm just going to show you a video. I hope you can all hear that.
Hi, Lynette. Sorry,
Hello.
we're not able to hear the video.
That's a pity. So where should I share sound? Yes. Let's see if that
active
works.
within their own home. So we do that by helping
work,
people.
Lauren?
Yes, we can hear it. Thank you.
Identify what some of the risks may be around their house, looking at how we might be able to either adapt to the environment to help alleviate those risks, or help support people to change their behaviour, educate them on ways that they might be able to do something differently to keep them as safe as possible in their own house. Some of the common risks we find in people's houses are trip hazards such as mats and rugs. Climbing and reaching for things is another huge risk that we find in people's houses. Looking at their mobility, whether there's anything that can possibly assist with their mobility around their house. Looking at lighting outside as well, and rails at stairs as well. Getting out and about in the community is so important for people from a social perspective. Looking at strategies as to how to get on and off trains, how to get on and off buses, up and down those bus steps. safe walking strategies, walking with a heel-toe gait, particularly when they're on uneven surfaces and things. It just allows them to be a bit more stable and less risk of tripping. An occupational therapist can be vital in looking at sort of the holistic life of somebody, helping them make sure that they can be as independent as they want to be, reduce their risk of falls, be safe living in their own environment, and be confident to do what they want to do.
So I hope that's given you an overview of the role of occupational therapy in general. So I'm now going to talk to you about a few studies that we have been doing in how to look at trying to prevent falls amongst older people in the community. So Jenny gave us a very good introduction to the need for this, certainly for people in residential care, but it's still a huge issue, certainly as the population is aging, for older people in the community as well. So we have talked a bit about using MBS or CDM items in order to gain access to those sorts of services for people that maybe aren't involved with a hospital or a rehabilitation centre. So we had a look at how private occupational therapists and physiotherapists actually use MBS items. This was in 2012, so it's a fair while ago, but it was still fairly early on, and how that fitted with their practice. So it's a qualitative study, and they all said that communication and collaboration between the providers was critical to the outcomes. Unfortunately, this had to be self-funded really by the allied health professionals because they weren't funded for that. But a lot of people took on those sorts of needs to be able to communicate with each other about what they were doing with people, and certainly to communicate backwards and forwards with the GP. There was an issue about understanding each other's roles. So that's again why I start off always talking about what occupational therapists do, just so that people aren't duplicating things if they are working with the same person. And they all felt that the MBS items were very valuable because they allowed older people to access allied health professional services a lot earlier than they would have been otherwise, because usually you have to wait till an older person injures themselves before people then go to hospital and gain access to rehab services. So this allowed people to get more help earlier. But everybody, and I think this is a common lament across the allied health professionals, that 5 items a year is simply not enough to do best practice. And there's plenty of evidence that 5 sessions would not be enough to assist people to become less at risk of falls, especially when you know the professionals are probably only being refunded about $50 for each visit, and it probably costs them over double that to actually do that as part of their private practice. So there are a whole range of issues with this, and certainly OT Australia has been working with Allied Health Professions Australia to try and improve the number of sessions that are available, because obviously people have access to 21 different allied health professionals. So the idea that they would only be accessing services from OTs and physios is probably a little bit optimistic as well. Oh, and as I said, the low rebate didn't cover the costs for those therapists. So this article is basically another qualitative one about how the results of us implementing a pilot project to do a falls prevention program using those 5 items with 2 different GP practices in New South Wales. One was in Sydney and the other was in Toronto. So it was sort of, we called it regional, semi-rural. So what we did was we used those those items to actually put together a program which is identified in this article. I won't bother talking to you about how we used those items, but it used exercise and home modifications as the two key interventions that we know work with falls prevention interventions. So we used the 5 items and used both OT and physio sessions in urban and semi-rural. We had 2 general practices, 3 OTs, 3 physios, and 8 older people actually took part in the pilot. We only had a very small amount of funding to help try and get this off the ground. The time taken to undertake the program became an issue for people because, again, it was a balance between how long it would take and how much it would actually cost the practice to implement the program. And some of the issues, certainly home visiting and getting all the home modifications installed, took more time than the items allowed for. There was a bit of ambivalence from the therapists about the outcomes and how tangible they were. And again, this is probably because it was a short time period. And a lot of therapists felt that it was more of benefit for preventive than high risk people living in the community. So felt it was much more appropriate to do this as a preventative intervention. And the patients or the clients that undertook the program all said that it was really important that the GP initiated the program with them. I mean, the GP needs to anyway for the CDM process to work, but for them to agree to do the program, they really felt that it was important that the GP felt it was going to be useful for them and communicated that to them. And we did see a lot of self-reported improvement in confidence. We have published another paper in about the quantitative outcomes, and we did see some improvement in some of the outcome measures, despite the fact it was only a very short and sharp program. So if people are interested in that paper, I can point you in the direction of that as well. So the other program I want to tell you about is the ISOLVE Falls Prevention Program, which was undertaken in North Sydney PHN. So they were our partners for this. And we undertook a cluster RCT trial, so similar to Jenny, where we had all the people within a practice, different practices were randomized rather than different clients within each practice, so that the doctors that were involved were literally separate from each other because they were in different practices. Of course, that didn't stop a whole heap of contamination happening because people know each other, and even the older people knew each other as well. So we started off with 27 GP practices that were put into the intervention or control group. And with these people, we had academic detailing, which we provided for the GPs about how to use some of the materials that we developed for them. We did trial some GP software, but that wasn't entirely successful for all sorts of technical reasons. So that's still something that needs to be developed in the future. And we had 525 patients in the intervention group and 566 in the baseline of the control group. So we just kept falls calendars, and we also surveyed the GPs every 3 months and 12 months during that time. We also interviewed the GPs that were in the intervention group at the end of the process. So there's a paper coming out looking at that. And it was very interesting that the GPs at the start, didn't really think about falls risk or falls prevention as a medical problem because it's not a diagnosis. So it involved quite a lot of rethinking of and reconceptualizing how the CDM items certainly could be used within this group. So we all, at the same time, we undertook allied health professional workshops across North Sydney, so that when these GPs did make referrals, they knew that they were going to be getting evidence-based interventions for their patients. And we also did a lot of interviews and pre and post surveys for those people. And we have also done an annual survey of all the GPs across the network to see if there are any changes in attitudes while the trial was on. So this is one of the items that we developed. So this was a kind of algorithm for GPs to follow with their patients. So we'd ask them to look at ask any of their older clients to complete a checklist, which is kind of like a self assessment of somebody's falls risk. Then somebody in the practice could review that. And if there was a yes to one or more of the risk factors that were included in that self-assessment, then we recommended that the GPs did a falls risk assessment of their own. And these are the MBS items that we used for that. And then there was a way for GPs to tailor interventions once they'd identified what the falls risks were. And then, of course, the follow-up with a person after their interventions had been implemented. If there was no sort of problems identified by the patient, then you could provide falls prevention information or refer on to community exercise that was available. So if we think about a person who might benefit from this sort of preventative approach, we can think about this lady who goes out, you know, so she, on the face of it, she probably looks perfectly all right. She's going out to the community centre. She's living with her plenty of support at home, and she's come into the practice for her annual flu vaccine. She has a history of asthma, which has been well controlled. She also has gastroesophageal reflux disease and some macular degeneration. So on the face of it, that looks like a fairly simple appointment for a flu vaccination. But if we were to go through the process that I've outlined earlier, Mrs. Chadron actually identified that she'd had some falls. And what we found was that very rarely did anybody, for that matter, not just the GPs, if they were asking, if they were meeting somebody who was over 65 for the first time, did they even ask if they'd had a fall? We call that asking the F question. And it is really important that all health professionals do that when they first meet an older person, even if they do look like they're fine. So despite the fact that Mrs. Chandran was probably quite mobile when she came in for her injection, she'd had a fall and was worried about falling. She was also saying that she needed to push herself up from a chair and needed her hands to do that. And she was also complaining that her eyesight made it difficult for her to see where she was stepping. So there's already a few items that have been identified from this person. So she had slipped and fell a few months ago in her living room, but hadn't injured herself. She'd had a recent eye examination, which showed her macular degeneration was deteriorating, but she was concerned that she would fall again. She was concerned that she might lose her independence. And obviously older people know about other people that have fallen and had serious outcomes, and she was worried about that. And it's important that people notice how people are mobilizing when they actually come in and out of a consulting room. And she was shuffling a little bit when she was walking towards the consulting room from the waiting room. So this is the sort of example of how to complete the GP sort of risk assessment. So things to do with balance were an issue. Things to do with vision were an issue. So there were already some things that the GP could have acted upon for her. And these were the tailoring of those sorts of items. So it's a whole list of things that could possibly help for someone that has had a fall or is worried about falling. And there's the benefit of having an occupational therapy assessment for home safety because of a problem with vision. So there are several things that could be done to help this lady and reduce her falls risk. And there were downloadable GP fact sheets that could be given to her to take away from the program that we set up. So the Stepping On program is one example of those interventions.
My name is Megan Swan. I'm an occupational therapist and I've been involved in Stepping On now for 20 years. Stepping On is a fantastic program. It's for people who have had a fall or fearful of falling. It's a 7-week program for 2 hours a week. Falls, as we know, is never one thing. It's quite a multifactorial problem. So not only do we cover strength and balance exercises, we also cover home hazards, medication, community safety.
Sorry, I've pressed the wrong button.
Vitamin D and calcium, shoes. What I see is that people are quite socially isolated once they've had a few falls because they don't want to get out and about anymore. The participants in the group use their stories to understand their own falls risk and to work out what's the reason behind their fall and what they can do to reduce the risk of falling. People learn to laugh, to smile, to make friends again, and they realise they're not alone. By the end of the Stepping On program, a large proportion of people have changed their behaviour quite a lot. They definitely are doing more strength and balance exercises, they're getting out more, they're aware of their own appearances, they've looked at their medication, they've got their eyes checked, their shoes, they've changed their shoe wear. I am amazed at how people can come to the program feeling quite disempowered and loss of control with their lives, and they understand what they can do to get out there and become more independent and stay up on their feet and reduce their risk of falling.
So you can see how the Stepping On program is very valuable for improving a lot more than just falls risk. It improves confidence, it improves self-empowerment, as Megan was saying. So another project that we're involved in that's currently being undertaken is with Sydney Health Partners, where we're trying to adapt the Stepping On program for people with mental illness, so serious mental illness through mental health services. And we have sort of worked on changing the program to suit this group because people with a mental illness have much higher risks of falling, and this can be due to quite severe antipsychotic medications that they might be on, a much more sedentary lifestyle. Often a lot of people are living in isolation, so their symptoms could make them even more sedentary than usual, and frequently people have gait and balance problems, which may be side effects of some of the medications that they're on. So we're currently doing a pilot randomized control trial, again for participants in Northern Sydney LHD. But unfortunately, we haven't been able to do a great number of these face-to-face programs over the last year, as you can imagine. So we've completed one, and we're just waiting for all the lockdowns to resolve themselves so we can finish the second one. So that's basically an idea of how occupational therapists might work in the community, giving you the example of falls prevention. I should also mention the example of driving, because that is a huge issue as the population is aging. And there are a lot of occupational therapists that are working with older people to assess their capacity to remain driving. So that's another issue that I think is going to become much more topical and much more important as we go on. So I've also put together a few slides about occupational therapy with older people in residential care. And as I said, Jenny's given me an incredibly great introduction to that. So there are things I can skim over here. But again, we're looking at safety. So we, you know, as Jenny mentioned, falls are incredibly frequent in residential aged care. But despite the fact that people are living maybe in high care areas, it's still important for them to be as independent as they want to be. And I think that there'd be occasions where people want to do some things differently and may be prevented from doing so. There's a thing about dignity that I think is quite important in a residential care facility. I'm on the board of a residential care facility, and we often talk about these sorts of issues. It's part of our sort of business. And there are some huge issues for making the environment, as I said right at the beginning, a caring environment for older people, because it is their home. And older people want to engage in meaningful activity, just the same as the rest of us do, to make our days purposeful. So here's another study that has been done just to look at what some of the circumstances were around serious falls in residents of Australian nursing homes. So these are all falls that resulted in a fractured femur. Of course, there'd be any number of other types of falls in this setting, but we just looked at fractured femurs for this analysis. And we looked at a total of 401 falls reports across 88 residential care facilities in the Hunter, New England area. And most of the associations we found with these falls were being ambulant. So as Jenny said, just going walking actually increases the risk of exposure to risk of falls if some of the strength and balance capacities aren't there. Having dementia, those that had dementia fell more often. Increasing age and having a high falls risk assessment undertaken by the nursing home. And when we looked at qualitative data provided in the falls reports, there were often a lot of resident-related factors. So there were a lot of behavioural factors that went into reports. So some people had been thumped by another resident, or some people had the organisational and environmental issues were often around the dining room, because that's where a whole range of people with disabilities are all squashed into one space. They're all hungry, they all want to get in there quickly, and people were falling over furniture and walking aids and wheelchairs and all sorts of things. So there were some issues about how the environment of the residential care home was organised as well. And some people were knocked over by trolleys for medications and things like that. And also the activities that people were undertaking at the time of the fall. So obviously getting to the bathroom is a key issue in the middle of the night for older people. So just to finish off, I want to talk to you about ELSI, just to give you an idea about how an OT could intervene. And now that we have these MBS items available, makes it much easier for us to be involved without being told to massage somebody or give them some TENS, which isn't really occupational therapy if you looked at my definition of what that was right at the beginning. So let's talk about Elsie. Elsie's aged 85. She's lived in residential care for about 2 years and was deteriorating following the death of her husband in 2014. So she lived alone for a little while. She'd been diagnosed with mixed dementias, so vascular and Alzheimer's. She has asthma, hypothyroidism, restless legs syndrome, which would cause a few problems with getting her to stay in bed during the night if she was becoming uncomfortable, and bilateral past cataract surgery. You can see she's had a bit of a fall here and has a bit of a bruise on her cheek. She's also quite agitated at times and could be violent. She was known to throw her walking stick around and try and hit people and things. And she also called the police once and complained that she was being held against her will. But she also had a history of frequent falling. So she was falling about twice a week. So when we sort of started to think about how an OT could intervene in this situation, we knew that she enjoyed music, but she often wasn't actually participating in any music. She was sort of just being asked to listen to it, which I don't think gave her much purpose. She'd lost about 4.5 kilos and had been referred to a dietitian. But she had difficulty feeding herself, and she often made a mess of her dinner, and it often came off the plate, and she had a great deal of loss of dignity because of that. She had several falls, and they always seemed to happen at a time when she got really agitated. And as I said earlier, she'd been hitting people with her walking stick when she became agitated. And despite the fact that she was on a low bed and all the sensors were put in, she was still continuing to fall. Probably something to do with the restless leg syndrome as well, I would imagine. She would just get up and keep doing it. And the problem with the sensors was that if the place wasn't responding to the sensor quickly enough, she'd be up and off before anybody could find her. And that's when she probably fell anyway. So one of the interventions was to get a neurologist to have a look at her. And they discovered that she was suffering seizures after periods of agitation. And it was actually a seizure that she was suffering from, not a primary fall. And they seemed to be associated with her increasing agitation. She was swapped into looking at walking with a walking frame, primarily because she couldn't lift that and throw it at anybody, and to actually try and reduce her agitation that would give her the green light to use her walking stick as a weapon. She was we introduced contrast for her cups, plates, and the table itself, and introduced a plate guard. So that automatically meant that she was able to work out where her food was, and it reduced the loss of dignity that she was experiencing trying to feed herself. We also introduced contrast around the toilet door frame, and she could actually see where to go for the toilet all of a sudden in her room. And her room was fitted out with different bold coloured bedclothes, because it was all a lovely sort of beigey colour. Everything was a beigey colour in her room, so she had no contrast. Her bed was raised to the correct height so that she could actually independently transfer in a safer manner. And she was referred to music therapy by telehealth, and she was set up to play the piano as part of those sessions. So her participation improved. Whoops, sorry, you don't want to look at that. So the outcomes of this were that her falls have reduced to about 2 in 3 months. So these sorts of very small, they're not outrageous suggestions, but we were able to see a reduction in her falls. Her weight went up. I mean, she was able to eat, so that made a big difference to her weight. She didn't need a special diet. Her weight was restored. Her seizures were then treated and the agitation was reduced. And she has even recently been able to come off some of the medication to reduce her agitation. And she's enjoying her meaningful occupations with music a lot more. So there are a few issues for occupational therapy in residential care. First of all, it's often not recognised. And I think you can see there are some major issues for someone like Elsie in terms of their person, their environment and their occupations. The past ACFI funding for massage and pain management was basically the only way that occupational therapists could be funded to do work in residential care. And of course, that's very limited and isn't really occupational therapy anyway. And all the recommendations in the Royal Commission findings have encouraged the use of different allied health professions in that setting. So there are some issues there, but that's a work in progress, I think, for occupational therapy. And I'll just leave you with these resources. So there's all the falls prevention online workshops are available for free online. There are some for allied health and some for general practitioners. And as part of the iSolve project, general practitioners can still do their CPE points by going through these programs. So given that we can't go anywhere for CPD, that might be a useful option for some of you. And this website is for an online falls risk assessment called the Home Falls and Accident Screening Tool. So for those of you that are working in the community, this is going to be of use for you. We haven't actually developed a special one for residential care yet, but I think that will become part of our future work. So I think that's everything. So thank you very much.
Thank you, Lynette. We just have a few questions here just before we go on to Professor Low's presentation. So the first one is, how do you manage a situation when a person thinks they're independent but starts to deteriorate and is at high risk when returning home from hospital?
I know. Wouldn't it be great if we could actually solve that problem? But yes, there are huge issues with individuals who don't have insight into their conditions, especially if they're living alone and they've been discharged from hospital. It sort of brings home all the need for much better discharge planning and follow-up once somebody does come home. I don't think there's an easy answer to that one. Do you have any suggestions, whoever it was that suggested that question? No?
Nothing's come through just yet, Lynette.
No, I mean, it's all very individual as well, isn't it? So even with Elsie, there was a really good reason why she used to get agitated, and one was she was too cold. And she was cold, you know, so the idea sometimes that some people are not, what's the word, cooperating with our view of the world, sometimes it's real. And if we just listen, we might be able to find out what's happening with someone to make them believe that things are different to what they are. So I think that's probably my biggest piece of advice.
Thanks, Lynette. We're just short on time, but I might just ask this last question. So dementia behaviours are escalating due to confinement and reduced staff and social support. With reduced staffing and constant change in managing COVID in the aged care facility, any suggestions on exercise in RACFs that care staff could implement?
Well, I think Jenny gave us some really good options that are inexpensive and should be reasonable to implement. But I would caution against everybody sort of using these freely without consulting with a physiotherapist or an OT to see how they can be supervised. But certainly I'm fully aware of how the COVID situation is diverting attention for everybody in residential aged care. As I say, I'm on the board of this one and we get emails every second day about things that are going on there. So I think at this particular time, it's particularly difficult for people to do extra. Yeah.
Great, thanks, Lynette. Just in terms of time, we might move on to Professor Low. There are a couple of other questions here, but I might get you to answer them at a later stage. Yep.
Yeah.
Okay, great, thank you. So just moving on to our last speaker, I'd like to introduce Professor Lee-Fay Low. She's a professor in aging and health at the University of Sydney, presenting on rehabilitation for people with dementia.
Hello, everyone. You've been sitting very quietly and attentively, so I thought we would interact a tiny bit. So when you see the word dementia, I'd like you to type in the chat what you think, what comes to mind, and what you might feel when you see the word dementia. Don't all type at once, guys. Isolation, thank you, Nikki. Confusion. Decline. Uncertainty, definitely. Any more? Depression, absolutely. Loneliness, reduced confidence. Yep, unable to understand. Yes. Yep, it's definitely an old age, more common old age. It's about memory, it's about forgetting. Second guessing, yep. Yeah, definitely. People with dementia are misunderstood. They have trouble, we have trouble understanding them. They don't always answer us. Unseen, unheard, unvalued. Yep, thank you. Loss of identity, thank you. Any more? So we've been asking this question to a lot of people in the last couple of years, and we often get answers like you've given us, about the symptoms of dementia, about what it feels like to have dementia, and sometimes about what it's like to have to work with or support people with dementia. What we usually don't get is about how to treat dementia. Sometimes we get that there are no treatments. And I just want to contrast this to if you said the word cancer, that we would get suggestions about radiotherapy, surgery, chemotherapy. And my message to you tonight, I guess, is that besides the medications, there are rehabilitative treatments that we can do for people with dementia, and there's growing evidence about these as well. So just to remind you that rehabilitation is a set of measures that helps individuals who experience or are likely to experience disability to achieve and maintain optimum functioning and interaction with the environments. And you'd know that to get a diagnosis of dementia, you have to have cognitive impairment and functional disability. So, by definition, people with dementia are, ripe or ready to have rehabilitation. And that rehabilitation is to really prevent the loss of function, or slow it, or improve or compensate for lost function, as well as maintain current function. So there's lots of research on dementia, the most common form being Alzheimer's disease. And this research is focused on prevention, on cure and delay, and on care. And increasingly, we're seeing more, rather than just thinking of caring for people with dementia, we're seeing research on how to rehabilitate people with dementia. And both Jenny and Lynette talked about, physiotherapy and occupational therapy kind of approaches to this rehabilitation already. I'd like to kind of, I think as alluded to in some of your chat comments, that that dementia isn't just a physical disease, it's a social experience, and that people with dementia experience isolation and they experience stigma, and we need to think about how we keep them part of the community and keep people with dementia valued as well. As I said, there's growing evidence for rehabilitation. Kate Lave and I edited a book which came out at the end of last year on the evidence. I can't go through all of it today in the short time I have with you. We already heard about occupational therapy and exercise. I think you've probably heard lots of talks about behavioral support, medication management, including cholinesterase inhibitors and deprescribing, for example. So I'm not going to talk about those, or carer support. I'm going to talk specifically as a psychologist about cognitive focused interventions and psychological interventions. While I'm talking, put in your chat if your service offers any of these types of rehabilitation. You might not be calling it rehabilitation, but these types of services and therapies for older people and people with dementia. I'd be quite interested to know what you're doing out there. So there's three groups, I guess, of cognitive focused interventions for people with dementia. There's cognitive training. You can think of it as brain training. It's focused on improving specific cognitive functions, for example, memory or speed or attention or problem solving. It's often computerized, though not necessarily, and it's basically focused on maintaining those cognitive skills. There's another group of interventions called cognitive rehabilitation, which actually looks a lot like occupational therapy. Often is done by a neuropsychologist, psychologist, or an occupational therapist. It's done in the person's natural environment at home. It's individualized, it's goal focused, and it's really focused on improving that person's daily function towards a behavioral or functional goal. So it's called cognitive rehabilitation, but to me, it feels a lot like occupational therapy, focusing on function, but perhaps with a more cognitive kind of flavor. There's also a type of therapy called cognitive stimulation therapy, and this is done in a group setting. It's been tried individually, but the evidence is not great for individually. So it's done in a group setting, usually in a clinic or in a daycare setting, and it's group activities. So they'll play games, they'll do quizzes, all designed to keep the person cognitively, socially, and sometimes physically kind of engaged as well. So just showing you a bit more about what cognitive stimulation therapy looks like. It's usually in small groups. They play games. There's really good evidence for this now, just showing you the forest plot for the impact on different types of cognition. They've done quite a few randomized controlled trials of cognitive stimulation therapy now, showing not just that it improves cognition, but it improves function and quality of life depending on the trial. There's some lovely manuals if you want to do cognitive stimulation therapy, manuals and videos. A health professional could pick this up and do this pretty easily, I think, from the manuals and the video. There's been a small adaptation for Australia run by the team at Prince of Wales Hospital. And, you know, I think it's a great kind of set of therapy, especially if you run group-based programs for people with dementia. Only a few aged care providers I'm aware of are actually running these programs despite the evidence for it. Cognitive training is much more cerebral, perhaps, less social. So it's on training a specific aspect of cognition, attention, color matching, speed, and this is just the results of the meta-analysis of cognitive training trials. So this is the bottom of that very long graph, and it basically shows, you know, a small positive effect on global cognition. The the tricky thing about cognitive training is that it improves cognition, but hasn't really been shown to generalize to other aspects of life. So if you train someone's memory, their memory improves. If you train their speed improves, but it doesn't help them in terms of daily function. So it's kind of tricky to recommend cognitive training kind of for rehabilitation for general functional improvement. Though if there's a specific aspect of cognition that's bothering the person, then certainly those exercises will improve that specific aspect of cognition. So cognitive rehabilitation, like I said, looks a lot like occupational therapy for people with dementia. So they help people meet different goals. So for example, learn to use email, to feel more confident when going out alone, to be able to cook a meal, getting distracted, to be able to dress, to help them with difficulty swallowing, to help them participate in enjoyable activity. So you see I put goals for people with milder dementia and more moderate dementia there. There's been one big RCT showing that cognitive rehab helps the person improve on those goals, but they didn't really show impacts on overall quality of life, mood, or cognition. So cognitive rehab helps the person in terms of their daily function and meet their goals, but we don't see generalization to other aspects, I guess, of other outcomes. But I think it has value irrespective of not generalizing to other aspects of life, at least in this one big trial. If you're interested in doing cognitive rehab, there's a nice manual out there. I think Linda Clare is putting out some new documentation on it as well. I just want to talk a little bit about dementia and psychological well-being. Because as I said earlier, dementia is a social disease, and people with dementia, having the diagnosis itself really impacts on how people feel about themselves, and that people with dementia are more likely to have depression or anxiety, and past traumas can reemerge as well. This is data from a 5-country study. I'm just going to show you our Australian data. We've been talking to people with dementia, interviewing and carers and health and social care practitioners, and we've been interviewing them. And what we found when we talked to people in the first 2 years after diagnosis is that it's a really devastating diagnosis. That care partners and people with dementia told us that when they got the diagnosis itself was a bit disabling. They felt shocked, they were sad, they were worried, there was denial. For some people it was relief, and then they didn't know what to do afterwards. And that the support that they got after diagnosis was, except for one person, really poor. And there was a disconnect between the diagnosis services. Most people we talked to weren't diagnosed by their GP. They were diagnosed by a memory clinic or a private or public specialist. The health and social care practitioners thought that they didn't really have the skills to help people through the system either. So this leaves kind of people with dementia and carers like they're meant to fend for themselves, and carers in particular felt that all the responsibility felt to them to get services for people with dementia, to get support, let alone kind of any treatments or rehabilitation beyond cholinesterase inhibitors or memantine. So this kind of I guess just follows on from the idea that very few people with dementia can access psychological or other mental health support. I'm just going to do a plug for Dementia Australia. They have free post-diagnostic support program. You don't even have to have a formal diagnosis of dementia to get it. They'll see people with MCI. It's free, it's by phone or online, and it's for 6 months of post-diagnostic counselling and kind of goal setting and care planning. So we actually know that psychological therapy for people with dementia works. So including the non-manualized kind of generic counselling like Dementia Australia is providing. We know that we can run problem-focused therapies for people with dementia and their carers, and they'll learn structured problem solving. And our team ran a more kind of CBT acceptance commitment therapy pilot study. We found that people with dementia, with mild dementia, could complete these sessions and got quite a lot out of it. You do have to adapt your therapy, goal setting. You really have to take time to get to know the person and set goals. Behavioral strategies sometimes are more effective to start with rather than cognitive strategies, depending on the person's ability. But, you know, and perhaps you wouldn't expect to see such quick gains, but certainly in our pilot, you know, we were very happy, I guess, with how great the adherence was, how engaged people were, and that they felt that, you know, coming to talk to someone about their diagnosis and some strategies, cognitive strategies and kind of adaptive behavioral strategies to cope with dementia made a big difference. We also found in our pilot that that helping the family adjust the diagnosis is very important. And even though it wasn't a core part of the therapy, almost all the people wanted to bring in their family and kind of talk about how dementia affected their family relationships as well. So who's offering rehabilitation for people with dementia? And we've been talking to people around all the states and territories about this. And my answer is, well, it's kind of variable. But we know that memory clinics, like specialized multidisciplinary memory clinics at least, offer very little rehabilitation, mostly because they're not funded to do it. So this is unpublished data. The full survey is published, but this bit of it is not published yet. So thank you to Sharon Naismith for these data, showing that of 86 people who worked in memory clinics who were surveyed, most of them, you know, over 70% of them were offering family support and some care planning and some risk reduction education, but very few offered kind of what I would call more traditional, more straight rehab, like computerized cognitive training or multidisciplinary reablement or memory strategy training, occupational therapy, speech therapy. Less than 30% were offering these types of support, and less than 40% were offering any type of psychological support, such as CBT or counseling for depression and anxiety. So we've been thinking, I guess, about where rehabilitation, how rehabilitation could be offered, where it could be offered within our current kind of systems. And certainly as part of the chronic disease management model, we are hearing about some GPs, particularly with support from the geriatricians or the memory clinic, prescribing rehabilitation as part of chronic disease management. There's some opportunities in hospitals, not in hospital, but in outpatient clinics to get some rehabilitation. And theoretically, you can use your home care package funding to get allied health treatments as well. I think that this happens sometimes. It happens sporadically, and from speaking to my colleagues in different allied health disciplines, that it's actually hard to find a good, experienced allied health practitioner who knows how to provide rehab for people with dementia. And when you find one, then you refer to them and you build that relationship. I just want to also do a plug for our website. We will have resources for people with dementia, for carers and healthcare professionals on post-diagnostic support. It will have a rehab twist. No, it will have information on rehab that will help people with dementia and carers understand the options, as well as things they can do, and you know what an occupational therapy, a speech pathologist, a dietitian, physiotherapist could do to help them as well. And to close, I guess, this is a very old quote now from the author Terry Pratchett, who said about his post-diagnostic journey, I guess, that he remembers on that day of rage thinking that if I had been diagnosed with cancer of any kind, at least there would have been open in front of me a trodden path. There would have been specialist examinations. There would be, in short, some machinery in place. And I was not in the mood for a response that said, more or less, go away and come back in 6 years. And I think Terry Pratchett's experience is what people with dementia and carers are experiencing now. in Australia based on our interviews. And I would really like that when you get diagnosed with dementia, you get offered some rehabilitation and some hope that there is stuff you can do to maintain your function or keep living, you know, your life. And now I will take questions or see what's in the chat.
Hi, Professor Low. Thank you so much for your presentation. I'm hoping there's some people typing away for you, but there was just a comment saying another great presentation, bridging the gap between research and practice.
Online programs. Oh, I don't know if I can recommend an online rehabilitation. I can't recommend any for kind of psychological therapies. It's none that I know of. I mean, there's online brain training. There's online brain training programs. None of the commercial ones like Luminosity have really been tested very rigorously. The ones that have been used in trials, I don't know if they're all available yet. I mean, I suspect that you could use them. Music therapies. I don't know about online music therapies, though I know quite a lot about doing personalized music therapy programs. If you're going to do music therapy, firstly, you could get a music therapist who works one-on-one with them. And then there's like kind of music therapy programs, which are individualized programs like music and memory. And Hammond Care have a nice manual, I'm pretty sure, on music therapy as well. The key with the music, with any kind of music program, is that the more tailored it is to the person's interests, the better. And, you know, the more you can engage the person, like rather than it being passive, I think the evidence suggests it's more effective in terms of behavior. I have not heard about sound therapy and tongues. I know that music, it sounds similar to the Hammond Care program and music and memory, but I haven't looked at it specifically. What got me interested in dementia? So, I don't know if this is relevant, but when I finished my psychology degree, I worked as a home care worker in a dementia-specific package, and I thought that the stuff we did, which was personalized and behavior management and tailored, and we worked with the ACAT and we worked with the GP, I thought that's what everyone did, and I was shocked to discover that the service, the small niche service I worked in, was quite unusual, and that's not what happened for everyone with dementia. Any more questions? Did we get an early mark, Lauren?
It looks like it. We might just wait just a couple more seconds just to see if someone's typing any questions. I think there was a question. Is there anywhere generally we can refer people for cognitive rehab?
So War Memorial Hospital has a program, a cognitive rehab program. You could refer there. I don't know who they'll take. We're RPA. We're starting a program associated with the memory clinic. I'm pretty sure St. Vincent's was running kind of a cognitive rehab clinic as well. One of the PhD students was running one there associated with their clinic, but there isn't kind of a standard service anywhere yet for cognitive rehab, sadly. I think that we're really, that firstly, the evidence has been slowly emerging for the benefits of rehab for people with dementia. and that we have to combat against, I guess, the stigma and the belief that nothing can be done for people with dementia. People, when we run training, people will still say, but can people with dementia still learn? And I'm like, yes, they can. They totally will learn new things, and that we have this, I think, stereotype belief that people with dementia, because their memory isn't very good or because their cognition isn't very good, that they don't learn new stuff and they can't benefit from rehab. Also, that we have to adjust our expectations, that sometimes they will not make gains as quickly, and you do need to adjust how you work with them. But you know, it's very satisfying when you do, because you can see results. I think I've answered all the questions now.
I think that's it, Professor Low. There was just another comment just saying thank you.
Thanks everyone for chatting and asking questions. It's very lonely presenting on Zoom, so it's nice when people talk to me back.
Great. I think we'll wrap up there.